Thanks for the invitation from this quite big stage for me. And I just like this presentation will be more about something that has already been told about how we can create models, about how we can kind of drive the change about implementing nuclear cardiology. So, next. Okay, nothing to disclose. So why nuclear cardiology is so important? So cardiovascular disease are still the main cause of death in UK for males. And also, but also beside the reduction, is still a strong second for females. Why this is so important? Because when we talk about nuclear cardiology, we need to understand if there is a demand generally for cardiology. And there is a massive demand for diagnostic cardiology overall. So there has always been a discussion about the competition between modality that was also highlighted by Professor D'Agostini about other modality coming over. But what I want to point out, there is a massive demand still for cardiac imaging in general as a whole because of the nature of the disease that is still so important in all our patients, in all our population. So why nuclear cardiology ex convention is so important? First is non-invasive. It's very, the indication are CID and coronary stenosis, guide medical therapy, monitor the treatment effort, can risk stratify patient, provide prognostic information, can assess myocardial variability. But like MPS is one of the stress imaging that is most widely used. There is a lot of culture about doing it, about performing it. Can be performed in many patients, like people having implanted metal objects, can be performed in patients with cardiac dysrhythmias or renal dysfunctions. And also, with the introduction of the pharmacological stress, MPS can be safely performed in a lot of patients that actually other modalities are more less safe to do. And why nuclear cardiology PET is so important? There is a lot of evidence that PET clinically has been all showed in these previous presentations. We have high spatial resolution, high sensitivity, we can look at tracer kinetics, and there is a attenuation correction decreases the amount of false positive. So you don't need a dedicated PET-CT because all the PET-CT now, they have the potential to do attenuation correction, also doing hybrid imaging. So what I found quite interesting is that recently there's been a couple of position documents between the European Nuclear Medicine Association and the European Association of Cardiac Vascular Imaging. So they also flagged the importance of hybrid imaging and multimodality. And like what they were flagging in this guideline, that a correct triage is the need to be used to choose the best diagnostic pathway. And also hybrid imaging in general, having the possibility to choose between multiple hybrid imaging modalities can give a support of a diagnosis. They made a clear example, they spoke a lot about PET MRI in cardiac infection. But also they talk about potential collaboration, the use of AI, the use of everything is important in the whole wider ambient of hybrid imaging. And also, I feel like conventional nuclear medicine and PET-CT are able to play a fundamental role with that. Also, what I wanted to stress in this is looking at modalities as complementary and not competitive. One of the things when I was part of ENM that we always discussed is the role of nuclear medicine inside the clinical pathway. So not only look at inside us what is best for the nuclear world, but also what is best for the overall benefit of patients. That is what is really important, that's what we are looking for. So what you need to do. So my idea is that if we want to do a new service or we want to drive a change, we want to implement more nuclear cardiology. So first you need to analyze what is the cardiological demand in the area that is mainly driven by the therapeutic procedure. So your area, your hospital, your things, how much what is used for cardiology? Is a specialist center, is a general hospital? All these things may differ when you need to drive the change. There is already cardiac imaging, which diagnostic provided. There are only perfusion or other clinical indication. So the focus should be on more common indication, but also we need flexibility because we may have different type of disease that we want to look for with cardiac diagnosis. So type of care provider play a role, location and catchment area, what is the healthcare culture in the area? Because if you want to drive the change implementing something, you need to have all this information set up. So you've talked a lot, I want to go to all what's PET-CT, cardiac sets, like we have a PET with rubidium. But also it's true, as you can see, it's much more populated. So this is more the real place where you are. You're not in a place where you have nuclear cardiology only. You're in a place where you have multiple modalities around you. That also plays a role. And a lot of people also interact. The cardiologists interact with all of that. And when you make a plan, a business plan of that, you need to interact with all of this. Also considering that MRI and cardiac CT, besides being invasive, are considered quite important in the study of things. And they are very, very well assessed modalities that we need to deal with, that we need to be complementary and working well together with them. So, new service or service improvement. So, this is what is really important. I need to ask myself, do I want to create a new service, like for example, a new cardiac PET service? Do I want to improve the cardiac output of my nuclear medicine department? What is the reason why my change is driven? And important to say, what is the volume of patient expected? Because it drives very simple question. I have enough admin to book patients. For example, if I change my department, the PET department, in a PET cardiologist, I will need to educate my admin for a different preparation to patients. And I may not have enough staff. Do I have capacity? Do I have all these things? All these aspects are part of the planning. And they are part of making what is been told by the previous speakers successful. There will be building works involved. Will our workforce be sufficient or with a sufficient skill mix? Who will take the stressing responsibility? Who will be reporting? All these questions have been asked. When you have to deal with people that comes for the business, for the planning, they will ask you all these aspects, and you need to consider that. You need to be ready with answers to these parts, because they will not ask you about like the details of some of the cardiac concept. They will ask you, like, can you do it? Are you actually do it? And which equipment they are available in the market? How much they cost? You want PET-CT, you want SPECT-CT, you want both. What is the problem? You have tracer. So we talked about the flow period just before the talk, and about like this amazing tracer it is, but it's not available in UK at the moment. And even in US, it's quite crazily expensive. Can we do it? It's part of it. And also we talk about technicians' unavailability. That is also play a role. We want to go around it. We want to try to get something. These are all parts of the business planning. And also one thing that I also stress is the expected length of the work. So when you create a business plan, you create probably for a demand that you have. We don't have enough capacity in our center to scan all the MPS. Okay, we need a new camera, more quick, more efficient and things. Okay, how much time it will take? Because if it takes 1 year, it's something that you can address immediately. If it takes 3 to 5 years, you may have a completely different scenario the moment that you implemented the change. So all these aspects need to be considered when you are doing the planning. So I did like a couple of graphs about what it is. Well, one aspect is the quality. So you want the best equipment, you want the best image processing tools, you want to be compliant with regulations, you want to have the best reporting of scan, and also you want workforce and patient engagement that provide a real clear help to the patients. You want to have the right workforce, you have to work the patients to be happy for what you provide. But also you have the finance. So what are the income and costs? Do they match? What is the demand and capacity? Can we adapt to the patient's workflow? This is very true for PET. If we implement, for example, a rubidium scan, we will have a completely different workflow from what it is the FDG scans. And you need to be adapted. If you don't have a system in that department to physically do it, you need to make change. You may need to also to do building works. Can you do it? Can you change? It's really, really something that you need to consider in these aspects. And also I put the same one, is workforce and skill mix. So workforce and skill mix play an important role, both in the quality, but also in the feasibility of it. I have enough staff, and the skill mix is the best one for what I want to do, also for the number of patients I want to scan. This is quite complicated. And also one thing that is really important, besides being in the bottom, is the engagement with clinical teams. So if you don't have the support of the clinical teams that go around, if you don't have the full support of the hospital when you try to drive the change, then it's something that became complicated. And you don't really want to sort the problem of these months. You really want to do something that lasts 5 to 10 years. And this is really important, what you want, or how the full clinical teams of your area support the change that you want to make. So conventional nuclear cardiology, why to choose it? Well, it's a well-established modality, long tradition, but with many recent innovations like cardiac central gamma cameras, CCT, SPECT-CT. I put wide availability of technetium. It's not completely true anymore, but like, let's say that because we had a lot of crises for that. But also it's very well embedded in clinical practice, so it's something that has been for ages in nuclear medicine, so it's quite embedded. It's cheaper, has been many slides before talking that it's a little bit cheaper than other. And also, it's very easy to do because wide literature on protocols and optimization, with it being so widespread, it's easy to have someone telling you how you want to do it. But I want, since you know, most of you know that I'm a PET person, I want to speak about a couple of experiences that I had about implementing a cardiac PET in the UK. Just to give a little bit of good news story, in sense like, it's something that is difficult, it's complicated, we don't know if it will be the future, but it's something that can be done. So I was talking about my previous experience in Barts Health, and I will talk about my actual experience at KCL PET Center. So in Barts Health, the background was the Barts Health Center is one of the leading specialist cardiovascular centers in the UK. Provides an important part of diagnostic pathway. But like the Barts Health centers have focused a lot on cardiac MRI, and the MPS were not considered any more competitive with other modalities, mainly due to the technology limitation. We had old cameras, we cannot really compete with that. And most of the imaging modalities, anyway, that were around us, had a lot of capacity issue. So what we proposed rubidium. So we had an improved diagnostic accuracy, reduced radiation dose, and also what was quite key in the case was the improved patient experience. We have fewer visits and shorter appointment times in the hospital. So 2 days protocol for MPS and 1 day for cardiac. So I could just go through the challenge and the solution. So one of the challenges was the limited cardiac imaging service capacity and prolonged waiting time. Okay, we decided to do rubidium. Okay, can we have lack of referral for cardiac PET? Well, actually we engaged a lot with the clinician, with the other modalities to try to understand if there was a need. And we looked at like there was a capacity. Another part is the cost of the generator. Generator or rubidium are really, really expensive. So we were sure that this could have worked. So we looked for charity support. And what we tried to do is to maximize the activity in a way to optimize the cost of the generator to make it viable. Another big challenge for when you start a cardiac PET is lack of PET capacity for oncology scans. I think in UK there is a general lack of capacity for PET scans. So can you really do PET for cardiac? This is one of the big questions that people ask about this. We had a solution with a mobile PET support that we increased, that was put as temporary, that became permanent to enable us to do more cardiac PET. And then it came the COVID pandemic. And this actually was something that really played a role, because rubidium PET became a lead modality scan. So in the time there was a decision-making about which of the diagnostic modality you can actually do during a pandemic. And like the hospital was very keen to do rubidium in 1 day to protect the cardiac patients, but we're not very keen to have patients coming 2 times for MPS scans. And this played a major role because we had a massive use of cardiac PET because of that. So I just go a little bit for the costing model of rubidium. Generators are really, really expensive kits. It's very different, the costing model, from what is the normal costing model of normal PET. Because first, the generator needs to be replaced, and it's very expensive. When you buy it, it's very expensive. And also, you need a card for dispensing, but the card can be rented, and there is always the cost of consumables, so this aspect. So, but you don't really pay for the dose. So you pay for the generator. And then how much you do makes like, the cost of what you pay. So you need to maximize the use generator to make it financially viable. And you need a lot of referrals to make it happen. Also, you need enough scanner capacity to make it happen and to make it financially viable. So what we did is like trying to make it viable by incrementing the numbers of referrals and creating space in the camera. So this was like what we did in Barts. I just go back a little bit in this to explain. So it really worked because we were able to transfer a lot of MPS from conventional nuclear medicine to cardiac. And then we create a culture around the cardiac PET that brought a lot of referrals, even from support from cardiac MRI and other parts. Why is important the support of cardiac MRI? Because in my new place, that is King College London PET Centers, the PET Center provides the clinical scanning for GSTT Trust, but also is very closely linked with the cardiac MRI service of the KCL. And recently, we were able to install 2 long axial field of view Vision Quadra, and 1 scanner was supported by a research grant. And so there is a requirement from our sponsor to investigate PET scanning for research and also beyond oncology. So when you have these big tools, you need to do something else than just scanning oncology patients. We had already a cardiac service provider for cardiac infection, and also we had some research study performed in PET MRI. And also we had a past experience in cardiac perfusion with ammonia, but we didn't do it with the new GMP regulation of the new lab that we did. So what were the research opportunity with PAB? We can look at new biological markers for coronary disease, comparative study between rubidium and other imaging techniques, investigation of use rubidium to perfuse in other body areas, such as the brain. So these were aspects that were discussed also in the case for the total body PET. It was part of the case. And unfortunately, we had to abandon ammonia, besides having the project on the pipeline. And the main reason was the release. So the part of the release of the tracer became very complicated with the regulation that were imposed. Because when ammonia, basically, when you create ammonia with the cyclotron, you need to do it in multiple runs. And there is a discussion about if the release can happen in these multiple runs. We had a lot of interest in using rubidium and recently developed a tracer like flurpiridaz. And we were able to get a grant. The grant was on multi-organ perfusion in congestive cardiac failure using total body PET. At the beginning, we were looking for healthy volunteers. So our rubidium was performing in healthy volunteers. But actually, the grant was given for patients that have already a story of cardiac disease. So what we want to do, use research for driving the change and implementing cardiac PET. Which are the milestones? First, we need to set up the study. Recruitment, a research fellow. The tender of the generator used to optimize recruiting. Protocol, post-processing, reporting. Clinical scans, we need to investigate the demand. But our drive is mainly research. And we have a start time now that is around the fourth quarter of 2025 with this new amazing camera. So conclusions, no. So I don't really want to do conclusion today. I just really want to speak about a new start because it was like the topic of all the session. And as a finishing note, my first invited talk at conference was on PET and SPECT in oncology in 2006. And at the time, PET was not fully established as an oncology modality. It was really, really still talking about it. Yeah, it's really good. It can be work. Now cardiac PET is not fully established in UK. So maybe, never know. Thank you.
Thank you, Giorgio.